Discussion started already.
Exactly, and everybody is expecting what you're going to...
Don't expect too much at the moment, please. Well,
go ahead, Djuro.
Well, George, Renato, thank you very much for the announcement, and really I would like to thank Evi Diamanti for the kind invitation to be the second time here on COMBO. On the first, I was on the first in the beautiful monastery in Viotia, I think, I pronounced nicely. So this time I had really a very hard task, as you've heard from the introductory from the beginning, and I don't think I will answer to all the questions, but maybe we can continue later on in the discussion. And as you've heard from Ilpo's presentation, this story is very complicated as well. So it's not only testosterone, but I think that growth hormone definitions and how to use it, how to define and to whom to give the dose is very complicated. So as you can see, we have a few things that we have to address. First is regulation. On the top of the slide, you can see the 3 proteins that are regulating the growth hormone IGF-1 axis. So these are the ghrelin, somatostatin, and GHRH. 2 of them are promoting and 1 is inhibiting. And this is something that we already know. But also stress and exercise is really influencing a lot to the production of growth hormone. And growth hormone is acting through the, traditionally, through the road to the liver, which is producing the IGF-1, which is then increasing the activity of the mesenchymal cells, producing the production of the bone, and we have linear growth, so we are growing on one side, but on the other side, on your right-hand side, you can see also the effects on the metabolism. So we have lots of effects on the lipid metabolism, increasing the insulin resistance and the free fatty acids, but also decreasing the fat mass. We have different effects or deleterious effects on the cardiovascular systems, and this is one of the key questions, and discussions are really ongoing. So we have the increase in myocardial mass, the left ventricular mass, cardiac output, and also the consumption of the oxygen. And finally, also on the muscles, you will see that we can increase the uptake of the amino acids, protein synthesis, etc. So this is one of the most complex hormones and one of the key endocrine axes that we have to know about, at least something for the general practice, how to use and how to define it. And this is maybe the answer, one of the possible answers to the question that was asked from the young colleague from Greece and the discussion that was started to be at the very beginning of this course. So these are the effects of the growth hormone, which could be direct or indirect or independent. And you can see on the left part the traditional pathway through the liver. So we have stimulation or influencing the production of the IGF-1 in the liver, and the effects of the IGF-1 on the other organ or the tissues and the whole body. But in the middle part, and especially on the right side, you can see that we have the independent IGF-1 effects. These conclusions came from the studies that make the animal knockout models. So they knock out the growth hormone receptors from the different tissues, and they saw that the tissues are not under the influence of growth hormone. So we have actually something that is done by the local IGF-1. So we have tissue type of the IGF-1 production locally. And now we can talk about the somatic production of the hormones. And this is a new era of understanding the processes in endocrinology. So we must know that one item or one thing is not acting on the same way on the different tissues. So maybe there is something within the tissue that could produce the similar effect. So we can see that on the brain, on the heart, and especially of the gonads, we don't have the direct effect of the growth hormone. So they have their own production of the IGF-1. I will remind you on something which is the aging of the growth hormone axis. And this is very interesting. If we are reminding the physiology of the growth hormone, we can see that the diurnal rhythmicity is very different between the young and the old persons. And with the young ones, we have those nadirs, you see, especially during the night. But this is actually completely opposite with the aging. So we have something that is disturbing the production of the growth hormones, and we don't have the pulses. We are losing the frequency of the growth hormone during the life. What could be the reason? One of the reasons is the changing of the sleep. So we can see, for instance, that growth hormone secretion during the sleep in the different age groups is declining. And you see that after the age of 40, almost we have half of the production of the growth hormone. And why is that? We can see that the slow wave sleep, this is the basal level of sleep, is declining. So if we change our habits by aging or by something that we are doing, like the social activities or whatever, night shifts, we can slow our basal production of the growth hormone. And on the other side, one of the possible explanations could be the cortisol. You see, the evening nadir of plasma cortisol is increasing during the aging. So in the later decades of life, we have increase of cortisol. So maybe those two hormones are in the opposite. So this is very interesting to know. And as Evi Diamantis said, we have definitely decline in the IGF-1's productions during the life. And this is starting after the age of 20. So after the age of 20, we have in every 7 to 12 years, half of the level of the IGF then till the end of the life. This is very interesting. So we have really definite finding that the IGF-1 could be a marker, and this is common for both males and females. So we have decline. We have decline in the production of growth hormone. But it's not very easy. And how to explain this situation? This is one very old paper that when I started to be endocrinologist, I was involved into the group that was going to the geriatric hospital, collecting samples with the stimulation of those two GHRH plus GHRP6 proteins that are actually trying to give us the clue that the hypothalamus is very effectively acting toward the production of the growth hormone. So what was really fascinating was that the combination of those two protein stimulators, we got even bigger release of the growth hormone in the oldest group of the patients. You see, from 75 to 96 years, we had extremely high levels of growth hormone. So this thing is not so easy, as Ilpo said. What are the consequences of the growth hormone deficiency? So we have lots of consequences. We could have the problems with the heart, hypertension, dyslipidemia, insulin resistance, atherosclerosis, of course, is increasing. Carotid intima media thickness is increasing, etc. Then with brain, etc. With bone mass and volume of the bone is declining. We have kidney problems with the decrease of the glomerular filtration rate. We have sarcopenia, muscle strength is decreasing, declining, and we have increase of visceral adiposity. This is very well known in the last 20 years. So everything of these is going into the cardiovascular and cerebrovascular mortality increase. And what is the history of GH replacement? First, in '59, we had GH from human pituitary. From 60s to 85, we have therapies only for the extreme growth hormone deficiency. So this is the history of the prescription. In 85, we were very scared about Creutzfeldt-Jakob's disease and the mad cows, you remember. In 1987, we had the use of recombinant GH. So this was the new era. And this was the start of the use of the growth hormone with the pediatric population. And from 2000 till today, we have revolution in the understanding, so we can use it in transitional period and during the life. So you see, we have some movements in the growth hormone therapies and the application of those therapies, but the data, longitudinal data from this section are missing grossly. So we don't have any longitudinal outcomes of those studies because it's very short in use, actually, I mean, obviously. What are the etiologies? Just briefly, we have growth hormone deficiency in children and in adults. So in children, we have mostly idiopathic in about 90%. Isolated growth hormone is in about a third of patients, and in 45% is the multiple hormone deficiency. So if we have growth hormone deficiency, it's very sure that we should have at least 1, 2, or 3 other deficiencies. Trauma is presented in a small number, and we have some patients, if we are working on endocrinology, we have lots of patients from the neurosurgery which are operated because of the craniopharyngioma. So we can add them growth hormone because they are completely hypopit. Whom and when to investigate. So if we are talking about the children, I will just address those first 2 lines. So when we have very severe short stature, so this is the height more than 3 standard deviations below the limit for that children, we have to treat or to consider for treating. And if we have height more than 1.5 standard deviations below the mid-parental height. This is something very useful for the clinical work, and we can very easily calculate the height of the parents and then add or decrease 6 centimeters from that, and then we can get the number. So we have to observe and take into the consideration when we have a short stature individual in front of us, so short child. What are the etiologies? We could have the genetic short stature, constitutional, skeletal dysplasia, etc., like glucocorticoid therapies and other syndromes like Noonan and Down, but these are the proven diagnoses that are now today accepted or verified to be for treatment. So these are growth hormone deficiency, Turner syndrome, which is a very interesting disease in the meaning of the very extremely high insulin resistance and treatment of growth hormone. Intrauterine growth hormone restriction, chronic renal insufficiency, these are the new diagnoses, idiopathic short stature, and Prader-Willi, which is extreme obesity for the treatment of growth hormone. So the yellow ones are those that we have to know for the clinical practice. I put this study, which is almost 20 years old, because this study is almost always repeated into all the linear studies that are coming till today. So if we stop the growth hormone therapy, we should have increased in subcutaneous fat, visceral fat, LDL cholesterol increase, and we should have decrease in muscle mass, bone density, and cognitive functions. So it's very clear that we have to treat the patients if we find the situation and stop treating. Why? Because we have patient in transition. So this is the child that we start to treat here. We are treating till the age, for instance, of 18. And then if we stop, we should have decline. And this is transition phase till the full formation of bone. So we have to treat the patient in that phase. This is very important. And this is a new, very interesting area new coming area for the treatment of our patients. What is the definition of this phase? So these are the starting in the late of the puberty and ending with full complete maturation. So this is something in between children and the adult period, and we have to consider that this is not the pure childhood or adolescent, and this is not the adult person in front of us. This is something in between. So this is transition patient with growth hormone deficiency. How can we evaluate? We have to do that after the stop of the linear growth, and we have to assess all the hormones and to assess the patient. How can we do that? So after 1 month of ceasing of the drug, if it is very severe growth hormone deficiency, we have to measure IGF-1, and if it is very low, we can directly treat. But if it is less than 2 standard deviations, we have to perform the tests, etc., and then we have to treat the patient. So if we have defined very low levels, we don't need to wait. We can treat directly, and these are also the indications that are accepted in the meaning of the reimbursement agencies in each of the countries. So what can we do? So if we have, for instance, idiopathic growth hormone deficiency, which is suspected from the hypothalamic origin, we can do, if it is very high suspicion, lots of tests. They are here on the bottom line. And these are the insulin tolerance tests, growth hormone, releasing hormone, arginine test, glucagon, and arginine per se. But today we are mostly using the insulin tolerance and the glucagon test, which are the gold standard. The gold standard is, of course, the ITT, but it's with some problems in performing. And these are the different international associations. Today we are accepting mainly this one, for instance, with the ITT less than 5 nanograms per milliliter, related to the growth hormone, and with glucagon less than 3. So if we do not achieve this level, it's growth hormone deficient. What are the doses? We start with 0.2 to 0.5 milligrams per day, and then in the month or two intervals, we are trying to adjust the dose toward the level of IGF-1. And then how do we treat the patient and monitor the patient? We should, every 6 months, perform the clinical evaluation. We should see if there is any side effects and to measure the IGF-1 and the presence of dysglycemia. Every year we have to do the assessment of the body mass index and measure the blood pressure. Quality of life questionnaires are today an asset. I mean, in every condition of the supplementation of any of the hormones, we have to do the quality of life. And every 2 to 5 years we have to do the lipid profile and to assess the DEXA. So the bone mineral density must be followed. What is the difference between the child and adult growth hormone deficiency? So the difference is, of course, the height. The adults have the normal height, but they have high fat mass with normal free fat mass, low IGF-1s, but normal IGF-BPs, binding proteins, high total cholesterol, and low HDL cholesterol, which is the same like with the children. So the main thing is the level, and we have the normal IGF binding proteins with the adults. How can we diagnose it? So if we have the children that has previously the diagnosis, we can just continue, of course. And the patients that should be tested are in the center of this slide. So those with signs and symptoms of hypothalamic pituitary disease, those that have received cranial irradiation because of the tumor treatment, and those with brain injuries or subarachnoidal hemorrhage. Those are the patients that we have to think about if they come to our office for the assessment. What are the clinical features? More or less they are the same as I said before. So we have body composition changings, very, very dramatic ones. Then we could have increase in the cardiovascular risk factors like increased cardiovascular mortality, altered lipid profile, atherosclerosis, impaired quality of life, and reduced exercise capacity. So this is very close and very tight related to the quality of life. So we must assess the oxygen consumption. What are the diagnostic tests? As I said, the most important ones are the ITT and the glucagon stimulation, and patients that have 3 or more pituitary hormone deficiencies and IGF below the reference range do not need any stimulation tests. We can treat them directly. What are the benefits of growth hormone therapy? We have increased everything. What you saw is negative will be positive. So this is increase in lean body mass, muscle mass and strength, decrease in fat mass, especially abdominal fat mass, decrease in cholesterol, increase in bone mineral density, increase in quality of life, etc. So this is one example. This is one of the studies that's showing that in the longitudinal follow-up at about 15 years, you see that there is persistent increase in bone mineral density, especially for males. Even if they were treated by bisphosphonates, they still keep on having a plateau or at least increase the bone mineral density. And this is one very complicated slide, but showing that we have increased in any of the studies that use different doses. We have decrease in total cholesterol, LDL cholesterol, increase in HDL, and decrease in more or less always triglycerides. So we have beneficial effects in the numerous number of studies you can see here with the really large number of patients. And how can we monitor the patient, or what should we do with the patient that is coming to us every 3, 6, 12 months? We have to assess the waist circumference and DEXA. This is very useful, very easy, and today it's available for us to take a tape and to measure or to send him to the DEXA. So serum IGF-1 should be measured at least yearly. How can we monitor biochemically? We must have really the biochemical marker. This is the best one is IGF-1. And we have to follow the cardiovascular risk markers. And pituitary imaging, we should never forget with the patients treated because of the tumor of the pituitary, like craniopharyngioma, as I said before. So thank you very much for the attention.